Hi everyone, welcome back to Izzy Medicine. Today we're continuing our shock series, so let's start with our patient. A 70-year-old man with a history of coronary artery disease comes in complaining of chest pressure and shortness of breath that started 2 hours ago. When you look at him, he's pale, diaphoretic, breathing 30 times a minute with a heart rate of 120 and a BP of 82/58. On closer exam, you see that he's cool to the touch. He has crackles at his lung bases, JVD, and thready pulses. This is when you start thinking that this may not just be a regular MI patient, but could possibly be cardiogenic shock. So, what is cardiogenic shock? This is when the heart can't pump enough blood to meet the body's needs. It's essentially pump failure, and if the pump fails, the whole system fails. But it's important to note that cardiogenic shock isn't just about the heart. It's about what happens when the organs don't get the blood flow they need to function. So when we say shock, we mean end organ dysfunction from inadequate perfusion, not just low blood pressure. But why does the pump fail? Let's break it down one cause at a time. And while we're at it, let's connect what's happening with stroke volume, cardiac output, and perfusion pressure. One problem can be mechanical. Let's say a huge chunk of the left ventricle dies during an anterior wall MI. Those dead muscle fibers can't contract, so we have less contractile force, which means with each pump, less blood is ejected, so stroke volume drops. When stroke volume drops, cardiac output falls too. And when cardiac output falls, mean arterial pressure takes a big hit because there's just insufficient flow to keep the pressure up. Sometimes an MI damages structures like papillary muscles, and that can cause acute mitral regurgitation, for example. Now, blood regurgitates backwards instead of moving forward, and that crashes the mean arterial pressure as well because we don't have enough forward flow. Electrical problems is another issue. For example, fast arrhythmias like ventricular tachycardia, SVT, or rapid atrial fibrillation, the heart beats so fast there's no time to fill, and with less filling means less volume to eject, which drops our cardiac output and drops our mean arterial pressure. Slow arrhythmias, on the other hand, like complete heart block, the rate is so slow that even if there is decent volume filling, the output is just too low to perfuse the body. Lastly, we can have muscle failure. And this is the worn out heart. Think chronic heart failure, acute decompensated heart failure with low ejection fraction, severe cardiomyopathy or myocarditis, for example. The muscle is just overall weak and barely squeezing. So we have low contractility, stroke volume is low, and the output drops, and mean arterial pressure drops as a result. So no matter what the cause is of pump failure, it leads to the same final pathway: low cardiac output, low mean arterial pressure, and organ hypoperfusion, and eventually organ failure. So what happens in response to this is that our body tries to compensate, of course. Through sympathetic pathways, it raises the heart rate. It's hoping to maintain cardiac output by pushing blood out faster. Also, it clamps down on the arteries to increase systemic vascular resistance to try to keep the pressure up. But unfortunately, that's a short-term fix. Like our patient here, who has a really fast heart rate of 120, his BP is still not maintaining, because if the pump is failing, making it beat faster or pushing against tighter resistance just wears it out more. It's kind of like revving a broken engine, you just burn it out faster. Let's do a little sidestep and understand preload in cardiogenic shock. In other shocks, like hypovolemic shock, for example, preload is low from bleeding or dehydration, so we don't have enough fluid to pump forward. In septic shock, preload is low because vessels are leaky and fluids are moving from the intravascular space into the interstitial space, so there's not enough fluid to push forward. But in cardiogenic shock, the volume is there, the tank is full, but the pump is broken. So what happens when the pump breaks? When the left ventricle fails, blood backs up into the lungs through the left atrium and causes pulmonary congestion. When the right ventricle fails, blood backs up into the right atrium, into the systemic veins, and causes JVD. So even though there's plenty of volume in the system, or normal high preload, the heart can't pump it effectively. It can't move blood forward, it backs up. So we have a classic cardiogenic shock picture with high preload, high afterload because systemic vascular resistance is increasing, and the heart is trying to push against that. Low contractility as the muscle is damaged for one reason or another, and low output. How do we know that it's shock? How do we recognize that it's shock and not just another MI? Well, shock happens when the heart's damage is big enough, or the rhythm is unstable enough that it can't generate enough cardiac output to perfuse the organs. And what does this hypoperfusion look like? Well, it looks like our patient. They're usually cold, pale, and sweaty from vasoconstriction. They're breathing fast and have low oxygen because there's pulmonary congestion. The lungs are being filled with fluid and the patient is essentially drowning from the inside. They have low blood pressure because we can't push blood forward and perfuse and maintain blood pressure, so their systolic is usually under 90. They have JVD because of this right-sided backup into the venous circulation. They have low urine output because the kidneys aren't getting enough flow and they get deoxygenated and damaged and they can't function properly. They get confusion because, again, not enough oxygenation and there's brain hypoperfusion. And they have thready pulses because stroke volume decreases, so every contraction is actually very weak. That's how you know that the heart is no longer keeping up and the organs are starting to fail. In addition to these clinical signs and symptoms, what helps us confirm cardiogenic shock? Well, we do an EKG, of course, to look for ST elevations, ST depressions, dangerous rhythms like VTAC or complete heart block. We do an echo because we need to see if the heart is squeezing well. We look at wall motion abnormalities. We try to catch valve rupture, right ventricular strain, tamponade. We also check lactate because when there's deoxygenation, the body switches from aerobic metabolism to anaerobic metabolism, and lactate is a byproduct of that process. And that signifies that the body isn't getting enough oxygen, and that's what shock really means, deoxygenation and hypoperfusion. We order troponins because anybody with chest pain and shortness of breath, it's very important. We also order beta-natriuretic peptide because that gets released when ventricles are stretched or there's damage, and that can indicate whether there's heart failure. And of course, chest x-ray to look for pulmonary congestion from blood backing up into the lungs. When we put all of that together, unstable vitals, signs of poor perfusion, imaging labs that show cardiac dysfunction, this is how we diagnose cardiogenic shock. So now that we've diagnosed it, how do we treat it? Again, treating cardiogenic shock isn't just about pressure, it's about function. Every decision we make in cardiogenic shock is about helping the failing pump and restoring perfusion. So we start with oxygen. We give high flow oxygen, or we intubate early if needed, because if they're in distress and their lungs are flooded, intubation may be life-saving. We consider fluids, because unlike septic or hypovolemic shock, as we alluded, most cardiogenic shock patients already have high filling pressures. So giving fluids may overload them more and worsen pulmonary congestion. But if we suspect that there's volume depletion, we can give a cautious 250 to 500 ml bolus and monitor our patient closely for signs of pulmonary edema that might be worsening. Sometimes the heart isn't generating enough force to push blood forward no matter what we do. This is when we need medications that increase the strength of the heart's contraction. And these are our inotropes. They help the pump squeeze. Dobutamine is usually first line. It's a beta-1 agonist that helps the heart contract better and also mildly increases heart rate. And that enhances stroke volume when the cardiac output is low. Dobutamine can cause mild vasodilation and can cause arrhythmias, so we use it with caution if BP is already low. And also, because it's a beta-1 agonist, it's not ideal for patients on beta blockers. Milrinone is a phosphodiesterase 3 inhibitor, and what it does is it increases calcium release in heart cells, and that leads to stronger contractions, but it can also cause vasodilation, which could be good for reducing afterload, especially in patients with high afterload or patients on beta blockers. The downside here is that the vasodilation and arrhythmia risk mean that we have to watch the blood pressure closely. So both of them have arrhythmia and blood pressure issues, and we have to monitor our patients. Unfortunately, even with inotropes, mean arterial pressure may still stay too low. And this is partially because both dobutamine and milrinone can actually worsen hypotension through vasodilation. So this is where vasopressors come in. They help maintain pressure that organs like the kidneys and the brain desperately need. Norepinephrine is first line. It constricts blood vessels and increases systemic vascular resistance and raises mean arterial pressure that way. This is the tricky part because increasing systemic vascular resistance makes it harder for the heart to eject blood. So why do we use vasopressors? Well, because at some point we need perfusion pressure, because if the mean arterial pressure is too low, no blood gets to vital organs. So What we do is we combat this whole entire situation by using the lowest dose possible of vasopressors to achieve a mean arterial pressure equal to or over 65. Of course, we give the inotropes first to try to support contractility, and we always monitor closely to see how our patient is responding to these medications. What happens if medications aren't improving output? What do? We can go with an intra-aortic balloon pump to reduce afterload and improve coronary perfusion. We can also connect our patient to ECMO, because if there's profound shock and the cardiac output is critically low, we need to support our patient while fixing the problem. And this leads us to treat the root cause, because nothing works long term unless we reverse the underlying issue. So if this is an MI, the heart muscle won't recover without revascularization. That means emergent PCI or a CABG. If it's an arrhythmia, tamponade, valve rupture, myocarditis, heart failure, that needs its own specific intervention. And of course, we think beyond meds. We need to correct the issue. The bottom line is that cardiogenic shock is pump failure, and we need to fix the pump. Otherwise, nothing else will work. All right, guys, that's it for the cardiogenic shock lecture. I hope you enjoyed it. I hope you learned and it was informative. And you can look forward to the neurogenic shock lecture or go explore the other varieties of shock or other lectures on Izzy Medicine. If you like this, please subscribe, leave a comment, press the like button. In the meantime, thank you for watching, and stay calm and keep saving lives. Bye.